pleasure to introduce Dr. Melissa Vanover today. It's funny how we forget sort of people's background when we think about the 6 to 7 years that we spend together in surgery training, that people actually had life before that time. Melissa has a unique background and started out with a bachelor's in fine arts from the Chicago Art Institute School of Art associated there before she made the transition to decide to go into medicine. Interestingly, for a while, she had a brief foray in thinking about becoming a veterinarian. I won't make the obvious comment about the possible connection between deciding to go into pediatric surgery and veterinary medicine, but she came with an interest in sculpture and the artistic aspect that goes along with that kind of work. So surgery was a natural transition once she entered medicine. She went to medical school at UT San Antonio before she came to UC Davis. She was an AOA graduate there. She has brought her creativity and zest for new knowledge and questioning the ways we do things to her time as a resident here at UC Davis. And I'm not at all surprised that she's coming today with a provocative talk, not about the common bile duct, for those of you who are going to be disappointed that CBD was not the common bile duct. I know, Dr. Galami, you're going to be okay. But we look forward to your comments this morning, Dr. Vanover, and appreciate all the great contributions you've made over the last 7 years. Thank you.
Thanks, Dr. Farmer. Apparently it's a lesson in the danger of the use of acronyms, but I'm sure this is not the topic that many would have expected from me, so I thought I'd start with some background. And it really all started with a question. So I was seeing a patient in clinic last year, a woman, standard preoperative visit for an incisional hernia, and we were talking about her expected recovery. And at the time, the risk of opiates were all over the news, and she was understandably concerned. So she asked me what my thoughts were about CBD and whether or not they might help reduce her need for postoperative opiates and maybe avoid them entirely. And I realized that I really had no idea that outside of my toxicology lectures in medical school, I couldn't recall any targeted education about medical cannabis to provide her with an evidence-based recommendation. And as it turns out, I'm not alone. Despite the steadily increasing number of states that have passed laws allowing cannabis use, only 9% of medical schools devote any portion of their curriculum to education about medicinal cannabis. And a recent systematic review and meta-analysis showed that amongst health professionals, including physicians and pharmacists, there was an unanimous lack of knowledge about all aspects of medicinal cannabis, from indications, risk, potential benefits, to dosing and even its legality. So this morning, we're going to talk about cannabis. Now I have an ambitious agenda to go over. First, I was going to start talking about cannabis as a plant and the chemical structure, and the two primary chemicals that we hear talked about, THC and CBD. Then I'm going to talk about the endocannabinoid system, which is how cannabis exerts its physiologic effects. I'll touch briefly on the history of cannabis use before focusing in on the criminalization and recent decriminalization in the United States. And next, I'll review what research actually shows us about cannabis, specifically during the perioperative period. And finally, I'll close out with what I would tell patients now, along with the particularities and the potential repercussions of recommending cannabis in California, should you choose to do so. So now, it's important to start saying that I have absolutely no disclosures. I have no conflicts, no financial interests related to medicinal cannabis. So with that out of the way, we're going to go ahead and dive in. So first, cannabis is a genus of flowering plants in the family Cannabaceae. They're dioecious, meaning that they're male and female plants, but both have a characteristic serrated leaf shape. It's believed to originate in Central Asia, and there's evidence of human use for nearly 5 millennia. Its fibers have been used for rope and fabric. The leaves, fruit, and seeds have been used for food as well as for medicine and for a variety of illnesses. But it also contains psychoactive chemicals, which were central to some cultural and religious practices, but now are most often used for recreational intoxication. So the symptoms of usage are pretty wide-ranging and have been well described, though they may vary from person to person and are highly dependent on dosage and chronicity of use. The most common psychoactive effects are things like sleepiness, mild euphoria, disinhibition, increased appetite, as well as some less pleasant effects like impaired memory and coordination, paranoia, hallucinations, and sometimes acute psychosis. Now, there are also physiologic effects such as dry mouth, red eyes, high blood pressure and tachycardia and bronchodilation. And in severe cases, cannabis can cause cardiac arrhythmias and arrest, seizures, and strokes. Now, the timing of onset varies by the method of administration. So inhalation is the most rapid onset. Typically, symptoms peak in about 15 to 20 minutes after exposure, and then they'll last for a couple of hours. When ingested orally, however, the timing is a little bit more unpredictable. Symptoms tend to peak at about 2 hours and can last for 5 to 6 hours, though some effects actually persist for 20 hours or more. And it's because of this that oral administration actually increases your risk of unintentional overdose and has seen increased visits to emergency departments. Now, the cannabis plant produces over 450 different chemicals, but the ones we hear about most frequently are the cannabinoids. So the two most well-known are delta-9 tetrahydrocannabinol, or THC, and cannabidiol, or CBD. Now, THC is thought to be responsible for the psychoactive effects, or the high related to cannabis use, and we'll see why that is in just a moment. CBD doesn't seem to have these effects, and we'll talk about that as well. Now, both THC and CBD were first extracted and isolated from the cannabis plant in the early 1960s in Israel by the chemist Raphael Mechoulam, shown here. He was also able to demonstrate in preclinical models that THC was the primary mediator of the psychoactive effects of cannabis, and subsequently research largely focused on THC, and CBD was largely ignored. It wasn't until the early 1990s, so not that long ago, that the receptors for these chemicals were discovered by a group at St. Louis University. There are two main receptors. CB1 is found primarily throughout the central and peripheral nervous system. There are high concentrations in the hippocampus, the basal ganglia, and the cerebellum, though notably the brainstem is spared, and is likely why we don't see respiratory depression with cannabis, unlike the opiates. The CB1 receptor can also be found in other locations like the liver and GI tract. But CB2 is located mostly on immune and hematopoietic cells, which are spread throughout the body. They're also found on some peripheral nerve endings and likely play a role in sensation of pain. So once the receptors were known, then we could look for endogenous molecules that would bind to these receptors, and these were identified and isolated again by Dr. Mechoulam and his team in the 1990s. Now, this group of receptors and ligands is collectively known as the endocannabinoid system, and while it's not been completely described, it does seem to have a very wide reach and is mainly involved in maintaining homeostasis. It plays a key role in regulating metabolism, modulating the response to stimuli such as pain, inflammation, or other types of physiologic stress. It also plays a role in synaptogenesis and memory creation, and is therefore critical to brain development during childhood. Now, THC and CBD have similar chemical structures to the endogenous cannabinoids, and so interact with the endocannabinoid system through variable binding on the CB1 and CB2 receptors. THC tends to be a partial agonist, particularly at the CB1 receptors in the central nervous system, which explains the observed psychoactive effects. Conversely, CBD acts as more of an antagonist at CB1 and CB2 receptors, and because of this is thought to have more of an impact by decreasing pain, decreasing inflammation, without the associated psychoactive effects that we see with THC. Now, with chronic use, there is a downregulation in the concentration of these receptors, and this downregulation is what ultimately leads to dependence and withdrawal symptoms. Now, dependence we see in about 9% of regular users, though this can increase to about 17% if regular use is begun in teenage years. To compare with other drugs, this study looked at the cumulative lifetime probability of dependence. And cannabis is way down there at the bottom at 9%. And I'd just like to point out that nicotine is way up at the top at almost 70% of patients developing dependence. Alcohol and cocaine are sort of in the middle. Okay, now withdrawal is much more common, actually more so than I expected or anticipated. A recent meta-analysis published in JAMA showed that the overall prevalence of cannabis withdrawal syndrome was 47% amongst regular users, and this increased to 87% for patients admitted to the hospital. And I just found that statistic really startling. Now, symptoms of withdrawal typically manifest within 7 days of cessation or reduction of cannabis use, and luckily are usually pretty mild and self-limited, things like irritability, poor appetite, sleep disturbance, and depressed mood. However, symptoms can also include things like nausea, vomiting, and abdominal pain, and this is therefore an important consideration for our post-operative patients who might regularly use cannabis at home. Okay, so we're going to switch gears for a moment. Now, as I mentioned, we're going to talk about history. So as I mentioned before, cannabis is thought to originate in China, and there's evidence of use in ropes and textiles going back as far as 2700 BCE. The fruits and seeds were used in cooking and are actually still used in Nepal as a kitchen oil. As far as medicinal use, cannabis is included in the oldest known pharmacopoeia, which is based on a long oral tradition, though it wasn't compiled until about 100 CE. And indications listed for use include things like inflammatory diseases, rheumatoid arthritis, eczema, and psoriasis, as well as constipation. And interestingly, Hua Tuo, who's regarded as the founder of Chinese surgery, actually describes using a compound of cannabis and wine for anesthesia. So from China, cannabis spread to India, where it's included in the Hindu Vedas as one of 5 sacred plants. The Vedas were written in about 1500 BCE. And it's described as a source of joy, a liberator given to humans to reduce anxiety and attain delight. It's often ingested as a drink called bang, though inhaled forms are certainly also prevalent. Medical indications were similar, things like pain, seizures, inflammation, although interestingly it was also used as an antibiotic and an antiparasitic. So cannabis continued to spread to Persia and Greece and then to the Middle East, where well-known physician Avicenna describes the use of cannabis as a diuretic and a digestive during the first millennia. And then in the 1400s, it was actually specifically used as an anti-epileptic for the caliph's son. So I imagine it worked, or we wouldn't have heard about it. Now, cannabis continued to spread via trade routes through Africa and Europe. And in Europe, cannabis was actually initially cultivated primarily for fiber. And then we finally spread to South America and to the United States. And in fact, the colonial settlers at Jamestown were required to grow hemp, which is a species of cannabis, which is particularly low in THC, and therefore used mostly for fiber rather than consumption. Now, the first modern descriptions of medicinal cannabis use come from the Irish physician William Brooke O'Shaughnessy, who in the 1840s was really impressed with the therapeutic effects that he saw when he was traveling in India. So he actually performed a series of quite rigorous studies, starting with preclinical models to confirm safety before using it in his patients for things like epilepsy and rheumatism. Hopefully you're seeing a trend. About this time, the French psychiatrist Jacques-Joseph Moreau also began testing cannabis on himself, his students, his patients, and while certainly less scientifically grounded, he did note improvements in mood, speech, sleep, and appetite. So over the next decade, over 100 papers were written about cannabis, and commercial preparations from some pharmaceutical companies like Merck, Bristol-Myers Squibb, and Eli Lilly were readily available. So with this long history of use and widespread medicinal application, what happened? What changed that made cannabis public enemy number 1? And I'm going to blame the French. Just kidding. But as interest and use of cannabis grew, it became quite fashionable to experiment with its psychoactive properties. There were cannabis clubs in Paris, the most famous of which is the Hashish Eaters Club, where writers like Victor Hugo, Alexandre Dumas, Charles Baudelaire, and others would gather and smoke. The British government became increasingly concerned about the consequences of recreational drug use and abuse, and with their strong financial interests in India, they actually launched a population-scale investigation into cannabis use. This culminated in the Indian Hemp Drugs Commission report, which was published in 1884, and concluded that occasional use of moderate doses could actually be beneficial, and that the repercussions of excessive use were mostly confined to the user with little impact on society as a whole. Now, surprisingly, despite these findings, cannabis in all forms was lumped in with opium and cocaine at the first international drug treaty, which was signed in 1925, and strongly restricted the trade of cannabis outside of India. Now, you may have noticed that I have not been using the term marijuana, and that is intentional. The origins of the word in relation to cannabis are actually quite hazy at best. What is known is that the term marijuana was used by opponents of cannabis use in the 1920s and 30s, ostensibly to make it sound more foreign, to associate it with Hispanic and Black communities, and thereby evoke racist ideas about the dangers of its use. With the release of movies like Reefer Madness and propaganda-like advertisements declaring marijuana a public menace, in 1937, the Marijuana Tax Act was initiated by Harry Anslinger, then Commissioner of the Federal Bureau of Narcotics. Now, these levied heavy taxes on the sale of cannabis and hemp for any purpose, which essentially gutted research and strongly discouraged medicinal use in the United States. And at that time, the Tax Act was strongly opposed by the American Medical Association, but nonetheless, in 1941, cannabis was removed from the national formulary and the U.S. Pharmacopoeia. So unfortunately, while medicinal use was being progressively inhibited, recreational use continued, further implicating cannabis as primarily a drug of abuse. This culminated in 1970 with the passage of the Controlled Substances Act by President Nixon, and it defined a Schedule I drug as having no accepted medicinal purpose and a high potential of abuse. Cannabis was scheduled as a classified as a Schedule I drug along with heroin and LSD. Notably, drugs like cocaine and methamphetamine are only listed as Schedule II. Now, the consequences of being of a Schedule I classification are significant. Research to evaluate the mechanism of action and efficacy in various diseases, which could actually legitimize the medicinal use or definitively prove their harmful effects, is heavily regulated, requires explicit approval from the DEA as well as other federal agencies. Funding can be very difficult to come by and often wants to focus on things like risks of use and abuse. Additionally, there's only one approved cultivator of cannabis for use in medicinal research, which is located at the University of Mississippi. And this cultivator only produces cannabis for inhalation. They have very few strains available and offer no edible or topical options. To make matters worse, researchers have repeatedly expressed concerns about the quality of the cannabis produced when compared to what's readily available to patients via the commercial or illegal market. In 2016, the DEA announced plans to expand the number of approved cultivators, and 33 different organizations completed applications, including UC Davis. But those applications sat unacknowledged for years. And in fact, a researcher from Arizona recently sued the DEA for delaying consideration of other bulk cultivators to aid her research on PTSD. Now, California was the first state to legalize the medicinal use of cannabis with the passage of the Compassionate Use Act in 1996, which allowed patients with the recommendation of a physician to cultivate and possess cannabis for personal use. This was followed in 2003 with Senate Bill 420, which established the medical marijuana program. This standardized the application process, clarified medical conditions, and required a state-issued identification card to help with law enforcement guidance. A series of bills in 2015 promoted development of a comprehensive regulatory framework for commercial distribution of medical cannabis. And the next year, the Adult Use of Marijuana Act, a ballot initiative that decriminalized recreational use, was passed by popular vote, and I was here when that was on the ballot. And finally, in 2017, the Medicinal and Adult Cannabis Regulatory and Safety Act established an overarching regulatory system for all forms of cannabis use. This includes 3 licensing authorities. The Bureau of Cannabis Control is the lead agency and oversees the medical marijuana program. Licensing for cannabis cultivators is through the Department of Food and Agriculture. The manufacturing branch of the Department of Public Health is responsible for commercial manufacturing practices, including packaging, labeling, as well as quality control. Final regulations from these 3 licensing authorities were actually just released last January. So actually January 2019. While California was clearly on the forefront of legislation, there's actually been a progressive push towards decriminalization, if not outright legalization of cannabis over the past few decades. Currently, there are 33 states with medical cannabis laws and 11 allowing recreational use. And if you include the medicinal use of CBD, there's really only 4 states with outright prohibition. Now, a recent survey from the Pew Research Center showed that there's been a tide change over the last 30 years, with 2/3 of Americans now supporting cannabis legalization. Additionally, a number of state and national organizations like the California Medical Association, American Medical Association, College of Physicians, amongst others, have released policy statements in support of decriminalization. The CMA actually released a white paper in 2011 which described the war on cannabis as a failed public health policy for a variety of reasons. The focus on criminalization and incarceration rather than treatment or rehabilitation has diverted limited economic resources, torn apart families, and disparately impacted communities of color due to inequalities in policing practices. And because underlying substance abuse disorders were not identified and addressed, continued cannabis use actually provided fuel for the illegal market and for violent cartels to meet this continued demand. Now, the white paper also noted that differences in federal and state laws placed physicians in an inappropriate position as a gatekeeper for medicinal cannabis while also exposing them to potential legal consequences, things like jail time, pretty hefty fines, loss of DEA licensure, and inability to participate in the Medicaid or Medicare programs. This can be detrimental, clearly, to a physician's career. So the legal landscape around medical cannabis is rapidly evolving, and keeping track of what's allowed is really difficult. But cannabis is currently the most widely used illicit substance, with approximately 24 million Americans over 12 years old reporting use within the last month. So it's particularly important that physicians stay abreast of the potential benefits and risks of cannabis use. So let's look at what the research actually shows us. And the most thorough review of the current literature from the National Academies of Sciences, Engineering, and Medicine was published in 2017. It is lengthy, so I will summarize their findings as this. There is moderate to strong evidence for the use of cannabinoids for chemotherapy-induced nausea and vomiting, for patients with chronic pain, particularly neuropathic pain, and for spasticity in multiple sclerosis. There's also a growing body of evidence for use in certain seizure disorders, and the cannabis-derived CBD predominant drug Epidiolex was just recently approved by the FDA. For all other conditions, this report found inadequate information to make recommendations. Now, the question I was asked was about acute postoperative pain and the potential to avoid opiate use. So extrapolating from the last paper, we can deduce that the evidence is going to be inadequate. I am not going to be able to give you an answer today. But I think it's at least worth looking at the data. So there have been a number of preclinical studies actually looking at this issue specifically, looking at if you add THC to opiates, what is the response to a painful response or a painful stimuli. And remarkably, all of these studies, preclinical studies, have shown significant reductions in opiate requirements. This paper is a systematic review and meta-analysis reviewing all of these preclinical studies, and So this shows a couple of forest plots. What you'll see is the IV formulations are on the left, the oral formulations are on the right. And amongst all of these studies, a move to the left of midline indicates that it favors the addition of THC for reducing opiate need. And so these are pretty impressive results, and these seem to be strong evidence for the use of cannabinoids. So what happens when we move to humans? Now, this is a little bit of a complicated study, and it shows the effects of inhaled cannabis on the sensation of a capsaicin-induced pain, which is a really well-established model of pain. And the study really showed two different things. It looked at both the effect of dosage and the effect of the time of a painful stimulus after exposure to inhaled cannabis. And so they used 3 different dosages of THC and 2 different times of painful stimuli. And what they found is that if you induced a painful stimulus within 20 minutes of exposure, that there was no difference between, let's see if this works, between the placebo and between any of the doses of THC. They all run along the same course. However, if you induce a painful stimulus an hour after exposure to THC, that the low dose was the same as the placebo. It runs right here along this center line. If you used a moderate dose, there was a reduction in pain sensation, which is shown in this lower line. And if you had a high dose of THC, you actually had a hyperalgesia response where the painful stimulus was more than a placebo. So that shows us that there are clearly differences in the dosage of THC and its effect on pain sensation. This is a little bit more of a complicated study as well. It also is looking at dose escalation after postoperative procedures. And what this one shows is that if you give the 2 Kaplan-Meier graphs here show the amount of time after administration of an oral cannabinoid drug and the need for rescue dose analgesia or the relief of pain. So this, let's see. So this graph over here shows that at the time of any dosage, a low, medium, or high dose cannabinoid, that there was some relief in pain, that you didn't require a rescue dose until a little bit later in the course. So low dose, in all cases, required rescue doses earlier. However, medium and high dose of THC allowed a certain amount of time without requiring additional opiates. So again, this emphasizes the dose-dependent response. This curve over here actually shows the amount of pain relief. So again, this is the low dose THC, and you found that there's no pain relief at about 5 or 6 hours, versus the high and the medium dose saw pretty significant improvements in pain improvements in pain sensation that lasted for 5 to 6 hours after administration. Okay, so looking at an internal control, so this is a patient that had some sort of traumatic injury, and this is a matched study looking at trauma patients that either received dronabinol after trauma or did not, and looked at the change in the opiate requirement 48 hours after the injury. So it allowed them to have the amount of opiates that they wanted for the first 48 hours, gave them a dose of dronabinol, and then after that point measured how much opiate was still required. And what we saw is that in all of these cases, there was a reduction in the amount of opiates needed after 48 hours that was greater than the controls, which are these 2 groups here. And those were both significant reductions in opiate requirements. So that's after trauma. So let's see, this all looks pretty promising. They're not very big studies. There's clearly more work to do. But let's see, is this even a safe drug to give to somebody? And so there was a large study looking at the assessment of side effects and other issues for chronic pain. So in these patients, medical cannabis was given to patients with chronic pain over 1 year. They saw significant reductions in pain, improvements in function, quality of life, and cognitive functions. The side effect profile was actually pretty good. They would have some mild side effects, but very few patients actually withdrew from the study or decided to stop taking the drug. And that their conclusion is that it seems to have a reasonable side effect profile. Okay, so after surgery, specifically, we're going to have patients that are going to come to us already taking cannabinoids. What does that mean for post-operative recovery? So this study actually is just it's a retrospective analysis, which is how most cannabinoid research is done. And it showed that the proportion of patients that arrived for surgery with a cannabis use disorder already documented in their chart has increased from 2010 to 2015, and it has nearly doubled actually in our surgical patients to about 14%. Active cannabis use disorder did not affect overall perioperative morbidity, mortality, length of stay, or cost. These patients generally did the same as patients who did not take cannabis before their surgery. However, there was a significant increase in the risk of MIs. And so looking at this, we said, that sounds a little bit concerning. Maybe we should look at how this affects anesthesia. What should we be telling our patients about cannabis use before surgery? And there are a couple of different papers looking at the surgical considerations and anesthetic reactions to preoperative cannabis use. And in all of these, they showed an increased risk of arrhythmias, of MIs likely related to tachycardia and hypertension, and strokes in chronic users. And this is actually seen in very young patients as well, as young as in their 20s. They also found increased anesthetic doses were required for laryngeal mass. This is important for those who do endoscopic procedures. You may require additional sedation. They also are at increased risk for chronic bronchitis, and things like isolated uveitis and upper airway obstruction were more common in these patients, particularly if cannabis had been used very soon before surgery. And so they recommended avoiding anesthesia for at least 72 hours after the last exposure to inhaled cannabis, as well as recommended routine querying of patients about their cannabis use. Okay. So in our patient, we have not found she doesn't meet any of the qualifying conditions for medical cannabis use according to California laws. And we don't have great evidence. So at this point, really you just I would tell her that, we're not really sure, that it seems to be relatively safe, that there are risks, and that if she has risk factors for heart attacks, for strokes, if she has a history of substance abuse disorder, or other, or a family history of psychiatric disorders, that she might want to avoid those types of products. The risk profile, risk discussion needs to include things like safe sort of storage of these medications, as well as the risk of impairment when driving. And so safety is very important. The Medical Board of California actually released a series of guidelines for recommendation of cannabis use, and again, lists the qualifying conditions here. So she doesn't meet any of those criteria, but should she come back in 6 or 8 months and has chronic pain, perhaps it would be something to consider. And so there are a list of requirements, things that they strongly recommend that physicians discuss with their patients. First, you really need to have a physician-patient relationship. If you don't know the patient, don't recommend it to them. Any evaluation has to include a physical exam as well as a thorough history. There needs to be shared decision-making, particularly discussing the risks and the lack of information, particularly regarding dosage and timing of onset. You need to develop a treatment agreement with your patient to monitor reaction and kind of the efficacy of the medication, as well as any side effects. You would have to list at that point what the duration of treatment is going to be, and that could be for a maximum of 1 year at a time for identification purposes, the medical marijuana program. You should send appropriate consultation and referrals as needed. So if they have concerns about chronic use and abuse, then you would refer them to substance abuse counseling. It's very important to keep complete medical records, including all of the discussions about risks, benefits, and alternatives. And importantly, the Medical Board of California indicates that we should avoid all conflicts of interest. Don't be employed by a dispensary. Don't have your office be located in a dispensary. You can't have any association with any of the products that you are recommending, and that clearly should go without saying. And then also discusses personal use, so avoidance of cannabis, because at this point cannabis is still a Schedule I drug. It's federally illegal and could have significant consequences for your medical career. They provide also an algorithm, and it's a little bit busy. Suffice to say, you should see your patient, evaluate them, discuss the options, and if you think that it might be something reasonable, you discuss and then you monitor and follow up. Okay, and because we can't seem to get away from it, there was a paper an article recently discussing whether or not cannabis might be helpful for COVID, and currently data is dubious. All right, it's a lot of puns in cannabis reporting. So hopefully this has been an informative session. You've learned a lot about the plant and its chemical structure, the endocannabinoid system, which clearly still needs to be elucidated. The primary takeaways are that we really need to encourage and reschedule cannabis from at least a Schedule I down to a 2 or a 3 to encourage and allow appropriate research so that we can provide recommendations for our patients. Okay, so it's come to the end, and I just have to say I'm I can't believe that in 2 months I'm going to be finishing residency. As they say, the days are long, but the years are short. And I have really loved my time here. No crying, not allowed. As Dr. Galante said when I first interviewed here, the best part about UC Davis is the people, and that is absolutely true. I've had really spectacular mentors during my time who've helped guide me, particularly during the last year, which has been a pretty tough time for me. And I couldn't ask for a better residency family, and know that I've made lifelong friendships. I do want to acknowledge my biological family also, who I'm sure are going to watch this as soon as it's up on YouTube. I specifically want to thank my parents who really modeled for me what it means to be a physician, how to take care of patients. And I can only hope to live up to their example. My dad is an internist, and he has been incredibly supportive, just through my art, my art history and art background, and then also in my desire to be a surgeon. I think secretly he wants to be a surgeon too. I know. My mother actually unknowingly, unwittingly, probably put this idea for this talk in the back of my head about 20 years ago when she recommended this book to me, which includes a whole chapter about cannabis and potential uses. So it's an excellent book for anybody looking for something new to read. And then last but certainly not least, my other half, David, who I think many of you have met and know. From the first time that we met 15 years ago, working at a pizzeria in Chicago, he has been endlessly supportive. He keeps me fed, clothed, sane, and I absolutely could not do this without him. So, on that note, thank you for your attention. I'd be happy to take any questions.
I'm sure no one is disappointed that you talked about the common bile duct. And it's really useful because it's hard to get this information, right? There's everybody's got their own opinion, everybody's got their own anecdote. Mm-hmm. I remember many years ago as a medical student in Seattle, people sort of sneaking marijuana to cancer patients in the hospitals. And I suspect that's been going on ever since. But we all just kind of turn a blind eye. So it's really important to try to understand this. What do you think the future is for the possibility of switching to a Schedule II so more research can be done?
Yeah, I would love it. I think there actually has been a little bit of a move in the last couple of years, although the DEA actually just rejected a proposal to reclassify it in 2016, so not that long ago. And with, not to get political in any way, but the current administration has certainly kind of shifted course on enactment of laws related to cannabis use. But I think that there is clearly an increase in public support. There is clearly an increase in medical community support, and most importantly, it's needed so that we can conduct the appropriate research, so we can make real decisions and provide real recommendations for patients. And so I'm hopeful. There's clearly been a move in the last 20 years, but I'm not holding my breath.
So, unlike the gun lobby and the active work on changing gun legislation, and for the purpose of gun research, really is what I'm talking about. There are vested interests. There's the trauma societies, the ER folks who are really pushing hard on lobbying to get the ability to do research on gun-related violence. It's hard to find who the lobby is and what that would be. Maybe the cancer communities?
Yeah. I know that there is actually a lot of information on some of the Cancer Society websites about cannabis use and cannabis recommendation, dependent on the state. So there actually is a lot of information. The primary driver here in Sacramento, in California, is actually Dr. Lyman, who's a retired physician and was on the board, the medical board, and he has been very instrumental. He's been kind of encouraging collaboration between some of the kind of recreational cannabis use groups and then the medical groups. He just actually gave a talk here last year to talk about where he thinks that this is going in the future. But yeah, unfortunately, I think the medicinal uses and applications have really been overstated, but so have the dangers. And so we need to have kind of a measured response and a encouragement for rescheduling. I'm hopeful with increased information, particularly with CBD, which is not psychoactive. It doesn't have the same mood altering abilities. That will be the ultimate driver towards legalization. There's actually some of the most impressive drivers are the pediatric epilepsy groups. There was a little girl who lived in Colorado who Sanjay Gupta, I think, actually talked about on his special, talking about cannabis use, and then found a bunch of other families with young children with treatment refractory epilepsy, and over the last 5 to 10 years has led to FDA approval of a cannabis-based strain of drug. So it's not a synthetic, it's actually an isolate from a plant, and that is the first plant, phytocannabinoid that's been approved by the FDA, and that was just, I think, last year. So I think there is actually a move. It helps if we have a good medical purpose, but I think that the need to study this is important.
Wonderful presentation, a great topic. Really, love it. I can repeat this question for the audience. If we cannot rely on the United States federal government to institute research into the role of cannabis in healthcare issues, what about the rest of the world?
Yeah, so most of the research is actually being done in Israel, in the UK, and in Germany. They have been actually pretty active in research. That's actually why Dr. Meshulam is on kind of like all the papers about cannabinoids, is because they don't have quite the same regulations, and they have been testing cannabis use in cancer patients since the 1990s. So there are other places that it's being done, but then pushing that same drug through the US FDA process is difficult. The drug for spasticity that's used in the UK is actually not approved here in the United States for just that reason. It's much more difficult to get through the FDA. So there are certainly, international groups that are working on this and are making some headway, but whether or not that translates to use in the United States is unclear.
Question in the back.
So, and I'm sorry if you touched on this, but some of the, did any of the studies that you cited, or are you aware of any studies that show a difference in the analgesic response between chronic users of marijuana and people who only experimented or naive? And does that analgesic response dissipate over time? Is there a tolerance to that?
Yes. So for repeating the question, yeah. So asking about naive versus chronic users and whether that impacts analgesic response and whether there's some tolerance over time. There are certainly differences in anesthetic responses. So naive patients have less complications than chronic users. They tend to have more airway hyperreactivity, more issues with hypertension and problems with MI, potential for MIs. As far as analgesia, I'm sure that I read one. I have probably about 200 references, and I'm not entirely sure. I'll be honest. I know that there are some differences also in the psychoactive effect of the drug, that chronic users actually don't have as much impairment as you might expect versus a naive user. And so I'm not entirely sure. I have to look. I can get back to you though.
Question from
Yes.
Yes. Ellis Hill asks, does withdrawal distinguish between THC and CBD?
It does not in these cases as far as I'm aware. So the withdrawal syndrome is specifically related to cannabis use, which has largely been reliant on the marketplace, both the commercial and illegal marketplace, which has traditionally been as high a percentage THC as you can get. There's actually been like 100% increase in the potency of THC over the last 10 to 20 years. And so that, with the dependence, tolerance, withdrawal it seems to be related to THC, but I don't know that it's been studied in CBD specifically. Again, CBD has really been ignored as like an isolate. Many studies actually talk about the synthetic compounds like THC versus CBD alone, and they seem to be less effective than an extract from a plant. Dr. Meshulam describes that as an entourage effect, that it seems to be this involvement of both THC and CBD to have increased efficacy for disease states. So I don't know exactly, but I don't know that it's been studied.
I have a question about lung cancer.
Yes.
So clearly, if you sort of date the increased use of smoking marijuana to the 60s, most of those people are in their 70s now, and you would think that this would be the time you would see some relationship if there was one, and there've been a lot of people smoking, the equivalent of a couple of pack years of marijuana. So is there any data on that?
There is actually a lot of, there's one pretty big study that I'm aware of looking at lung cancer in cannabis patients, patients that use cannabis. Interestingly, it's very difficult to differentiate between patients that only use cannabis and those that use cannabis and tobacco. So the proportion of patients is very small. The actual study population is pretty small. But there, interestingly, doesn't seem to be an increase in the risk of cancer. And part of that, I think, is because, yes, a single cannabis cigarette is equivalent to, more than one tobacco cigarette. It's something like 3 or 4 cannabis cigarettes to like a pack of tobacco cigarettes. But patients don't tend to just smoke all day long. Some do, but unlike kind of your tobacco smokers who just, chain smoking, you don't see that quite as much. And so the risk of lung cancer development doesn't seem to be there, but we clearly need to have better longitudinal studies. Also may be confounded by whether or not people were willing to disclose their use of cannabis. Interestingly, there does seem to be an increase in bladder cancer, but again, it's in a very small group, so it's hard to draw many conclusions.
Great. Questions from the video world?
We have a follow-up question from Ellis. Are the increased perioperative risks only with inhaled or also with edible?
It's primarily, it seems to be primarily inhaled. That the inhaled versions, because they cause more airway inflammation, cause more issues with anesthesia. The edible options will still cause hypertension and tachycardia, and so the risk of MI is still there. So again, I can't differentiate between THC containing products and CBD because that hasn't been looked at specifically, but ingested cannabinoids will cause tachycardia, and if you use that within a few hours of surgery, that significantly increases your risk of MIs.
So advising 72 hours,
Yes.
a little bit like we advise other smokers
Right.
to avoid might be helpful.
Right, absolutely. Most of the anesthesia societies have recommended avoiding anesthesia if at all possible for 72 hours after exposure. In fact, if they arrive in the preoperative area, to cancel elective cases if necessary, or if you determine that they were smoking the day before. You can't always do that, clearly, in our emergent cases. But again, it's very important to keep in mind the risk of withdrawal. So if you have a patient who uses every single day, and then you have them stop using 3 days before they come to the hospital, they are at much higher risk of withdrawal symptoms, and so may arrive with pain, nausea, vomiting. They might be real irritable, and you may kind of misinterpret those signals post-operatively to think that there's something more serious going on.
Any other questions? Well, thank you very much. As always, you bring your tremendous intellect to any problem that you attack. So thank you for that really great presentation, as well as your 7 years with us. So
Thank you.